we've done as a community is we've moved these drugs very quickly into the neoadjuvant space. And there are a plethora of neoadjuvant trials. There are some chemotherapy, immune therapy trials. There's cisplatin, nivolumab, for example. But there's all cisplatin, durvalumab to be represented, and pembrolizumab. But there's also EV pembro in both cisplatin eligible and cisplatin ineligible, and durva-tremi in fortunate vedotin neoadjuvant triplets. In some of the trials, you're giving a period before and after the surgery. In other trials, you're only giving it before. What's your take on this neoadjuvant space, whether or not these trials are going to be positive? We talked about PathCR before, but DFS and OS are both, I think, crucial endpoints. And then I guess the last piece is how easy is it from a surgical perspective, once we put these patients through these cycles, to do the operations, and is it safe?
Loaded questions.
You can handle it, yeah.
And only a few.
I know. So yeah, I mean, first of all, it's super exciting, right? We see these data and immediately our minds are thinking this is absolutely going to move into the neoadjuvant space, and how is that going to impact what we do afterwards? There are two ways to think about it. One is, are we going to improve the CR rate and hence outcomes of the patients? The patients who have CR with chemotherapy do extremely well. They have 85, 90% survival rate post-cystectomy. The question really is, how many of them need a cystectomy? So that same question is going to be posed once we move these agents into the earlier phases and do neoadjuvant chemo. If we see very high CR rates, you're going to see the next set of trials that are going to examine whether or not they need cystectomy. And again, that's going to take a while. That we're going to talk about again, what does it mean for CR. So we're very excited. The first phase is, of course, we've had the PURE trial with Pembro showing the 40%, 35, 40%, all the neoadjuvant sort of for cis-ineligible checkpoint trials show about that 35, 40% CR rate, which is interesting and exciting, certainly more than the 20, 25% we see with chemo. Question is, does it really make a difference on the other end, right? Do we still need the cystectomy, and what component is that treating? Theoretically, it's treating the micrometastatic disease. Do we have micrometastatic disease? Does every patient need neoadjuvant therapy? There are lots of these questions, and I think part of it will be with biomarker assessments, and the ctDNA is super exciting to me, to see whether we can actually select patients for.
And I have a question here, in these perioperative trials, even when patients do get CR, they continue EV pembro.
Right.
So is there really going to be a need for that in the adjuvant setting?
I think Sia's point around ctDNA is going to turn out to be important.
Yeah.
I also think the CR rate of 30% and the early responses you described, I can see those EV pembro trials being positive for survival. The chemotherapy, immune therapy studies, I think there is a degree of antagonism. I'm involved in all sorts of bits, so I don't think I have a huge but I just don't feel they're perfect even cisplatin-based therapy. I don't think the 361, the 130, and the study we've just talked about, the 901 trial, they don't seem to show a massive bounce in general response, and the curves seem to go apart afterwards. I'm a bit anxious about those trials because I don't think the two are acting together in a synergistic way. But there does seem to be something additive, at least, around the EV pembro, and with a CR rate of 30%, I would expect those trials to be positive.
I think bottom line, sorry to interrupt, bottom line, you have to think about this, with metastatic disease, you have disease that's already out there, right? It's outside the bladder. With localized bladder cancer, we have a clinical T2 or T3, there are some patients who actually have localized disease, right? We're over-treating a proportion of patients with systemic agents that really could have had a cystectomy, and then we're under-treating some because we only give them neoadjuvant chemo and then cystectomy and plus minus adjuvant nivo, but it may not be enough, right? We really need to sort out who has localized disease, who has actual metastatic disease, and I think that's, like you said, where the ctDNA comes in and other perhaps biomarkers to tell us exactly what's going on before it becomes radiographically evident. Because once it does, I think we've lost our chance.
And on that note, quickly, I think all three of us are part of the International Bladder Cancer Group IBCG guidelines, trying to develop a framework, some guidelines of how can design optimal trials to enable the concept of bladder preservation with systemic therapy alone. How can we rely on a clinical complete response rate after we properly define it? and correlated with long-term time to event endpoint. So negative cystoscopy, cytology, negative MRI maybe or CT, and potentially negative ctDNA, all of the above might help us select the patients who might be able to be eligible for bladder preservation with systemic therapy alone.
Trying to put me out of a job.
Yeah.
Or help us achieve the bladder preservation cure.